Thank you, Piotr. Thank you to our host, Professor Hager. I will speak about the conversion to hearing aid to cochlear implantation. I just show you a couple of very, very basic cases, not so more complicated. A female, 71 years old, with a family history of bilateral hearing loss, diabetes, lower limb thrombosis, with progressive hearing loss. You can see here on this left and right side a relevant otosclerotic process of the otic capsule with some cavitation, diverticula at the internal auditory canal, and so on. In 1995, she reached a profound hearing loss with anacusis. And in the left side, she used hearing aids, high-power hearing aids. She was referred to us last year in 2023. If we have a look here, we can observe severe hearing loss on the left side, anacusis on the right ear, and in particular with hearing aid in use, 0% of speech perception noise. This is truly strange, but it's not so unusual, at least in our clinical practice. We use for this a term. We say that this is the metaphor of EEG flat, because it's like a neurologist referred to a tertiary center to another neurologist, a patient just when the EEG is completely flat. So this is strange, but not so unusual. Of course, we perform a left implantation in this lady. We met an ossification at the round window level, a patent scala tympani. 12 months later, this lady could hear 83% of speech of the syllables, and she has a relatively good, for age in particular, at speech in noise test. But it's impressive, if you look here, when we consider health utility index, so an instrument robust to evaluate the quality of life, the impressive improvement she has, this lady. She doubled the score. This is another case, 20 years, female, with a genetic postlingual hearing loss, was referred to us also in this case last year, in 2023, but she has a very rich documentation, and you can see here the audiogram across 30 years of life, since 1993 to last year. And you can observe a severe hearing loss. She used hearing aid in both ears, abandoned the hearing aid in the left side just last year because of a progression of hearing loss on the high frequency. But let me show the speech perception over time. If you look here, we can observe a progressive decrease of speech perception in quiet over the years, till 30% at our observation. Also in this case, we implant the left ear, intraoperative findings were normal. This is the aided speech, the aided audiogram. The speech perception in quiet was 98% 1 year later. Speech perception in noise is mild benefit, 2 dB SNR. Also in this case, we had a significant increase in the quality of life at health utility index. Just to show you one dimension where she had an incredible increase in emotional limitation, a reduction, of course, in emotional limitation at another instrument for quality of life, the SF36. So, let me now generalize the problem. What the problem? The problem are two. The first is the underuse of cochlear implantation in adult population. You show also before in other lectures this impressive percentage. If we consider the journey of patients that usually arrive, the adult patients that usually arrive at a cochlear implant, we can use this representation, a long journey, winding and long and winding road, like the Beatles song you remember, I suppose. So, starting with first symptoms, then arrives some disabling hearing loss, then some, at least 1 out of 3 receive a hearing aid, and then someone of these people receive a cochlear implantation. We have from the literature a reliable estimation of this time, of this delay, 9 years in the case of hearing aid application. And if we consider first symptoms, is surely superior to 30 years in the case of cochlear implant. It's too long, this journey. It's really too long. But the problem is how can we shorten the transition between hearing aid, the conversion from hearing aid to cochlear implant? Well, if we consider the second case, if we apply a cutoff criteria, very easy, this is not a criteria for candidacy to cochlear implantation, but it's just a criteria for referral for evaluation of candidacy. If we use a 40% criteria of speech perception noise, 50% or 60%, this is the range of reasonable criteria for a screening of the aided speech perception. Well, we can see that if we used 40%, this patient probably received 3 years ago the cochlear implant. But if we used 50% or 60% criteria, probably received near 20 years ago the hearing aid. So, in my opinion, this is a point that needs to be discussed in order to give some information to hearing aid professional and other kind of healthcare professional in this area. The problem, in my opinion, to be underlined here, is the standard of care approach. We need to consider that a lot of guidelines built with grade approach exist actually, both for either for hearing aid and cochlear implant in elderly people and other population. So we have to work to bridge standard of care with real life situation, with strategy like adoption, dissemination, promotion, engagement of professional association, and so on. Thank you for your attention.